Good morning, everybody.
KPC is coming in another 5 minutes.
Okay, right. So, we are going to start the next session on riveting cases and refractive surgery. I request the audience to take their seats. We can commence the session. Each talk will be for about 4 minutes, and the first talk is by Dr. Doyle Biswas on reeled RIL.
Ma'am, I'm the moderator. I'll sit there.
Okay, who's
I was the moderator. I'll sit there.
what's your name? Okay, please do join us. So the other, Dr. Krishna Prasad, I think, will be joining shortly. And Dr. Amia Kulkarni, if she's here, can join. Yeah, okay. And Anusha Ajwani is here, and Gaurav Luthra is not here. Okay. So we'll start with the first speaker, Dr. Doyle Biswas. Is the speaker available now? Okay, then we'll go to Dr. Tejas, who will be speaking on phakic IOL interesting complications. Okay. So I think, should we go to the next person? Ipsita Konar, is she here? Yeah. Can you speak now on autocorrecting ICL? Are you ready? Okay. We'll go ahead with her. You were the speaker in the last session also. Okay, that's why you're standing there.
No, I came a little early.
Okay.
Good afternoon, everybody. Thank you so much for this opportunity. So I begin with a picture of a girl hiding behind the podium because I'm quite worried that could be my case at the end of the presentation, but then here I go. Refractive procedures can be laser vision correction, but then they come with the limitation. Okay, sorry. Okay, so laser vision correction, but they come with a limitation in the amount of refractive correction that can be safely treated. So then came the phakic IOLs to help us out there. So once upon a time, in the year 2017, a 22-year-old boy came to us wearing glasses, wishing for LASIK. He said if he got rid of his glasses, that would really make him happy. So when we examined him, his vision in the right eye was 660, left eye 612. Rest of the examination was within normal limit. And this was his refractive error. Now we realized that LASIK wouldn't be possible for him, so we discussed that he could go through ICL and that would take care of the problem. He could get rid of his glasses that way. He agreed for the same, so we did a IOL master white-to-white measurement and a manual white-to-white measurement. As per plan, we went ahead with ICL in both the eyes in October of 2017, a week apart. Toric ICL was implanted in both the eyes, but then the problems began. The vault size in the right eye after the surgery was 60, and over the years from 2017 to now it has varied from 60 to 207. His vision had varied from 612 to 624. Looking at the left eye, we at least began with a 186, but then through the years it has varied from 62 to 220. Vision also varied from 612 to 618. So he landed us up with a lot of questions that should we rotate or remove this ICL? Will he develop cataract? Why does his vision vary every visit? And what is our plan now? Now the ideal lens vault should be approximately 250 to 750 microns. And in his case, as I said, the lens vault varied from 60 to 207 in the right eye and 62 to 220 in the left eye. So the lens vault has never been more than 250, the minimum basic requirement. The patient was informed about the situation and explained the possibilities of developing cataract. Now, what are our options? To wait and watch, to explant, to rotate, but then it's a toric ICL. So will he develop cataract? Well, he may or may not. So far, he hasn't. Should we rotate or remove the ICL? In 2017, and since then, in all his follow-ups, the patient was always explained the possibility of developing cataract. He has always preferred to not have any intervention unless any complication develops. He has always been comfortable with his vision and still happy without his glasses. We have always kept the patient on close follow-up. Why his vision varies every visit? On dilated examination, we noticed that the ICL has rotated in the right eye from 7 degrees to around 50, and in the left eye from 18 to about 100. Since it's a toric ICL, the rotation results in the variation in his vision. The rotating ICL tells us that probably the lens implanted was of a smaller size and hence it is spaced to rotate. The smaller size also explains the low lens vault. What we consider boon and bane is his power being more of spherical nature, vision is nearly maintained. the vault has formed with more vertical rotation of both the lenses. Points we learned: the vast difference in the white-to-white measurement of IOL master and manual measurement using calipers should have prompted us to check again. We should have checked vault size after the first eye to get a clue about the problem with lens sizing before doing the second eye. 5 years since his ICL implantation, and there is no cataract development in spite of low vault size in both eyes. With the ICL rotating to more vertical orientation, it seems to be autocorrecting the vault size issue. But then we are aware that it can still keep rotating and come back to a horizontal position. So we plan to continue to monitor the patient and close follow-up. Thank you.
Thank you. I just have one question. What was the size of your ICL? That was 11.05.
Yeah,
and what was the size? Because what did you base it on? The manual?
We based it on the manual.
Normally, if it is 11, they give 12.5. 12.6 they give. 12.6 they give. Yes. So that's what you put in?
It is, yeah.
12.6.
But
so because it was a high myo, probably he had deeper sulcus. And that is a big problem. And sometimes, even though we try to do our best, I also had one patient who rotated constantly. And there was not so much of varying of power. Only thing, it used to come down just by one line. So I rotated it twice. And then she decided that she'll just stick to this and just leave it alone. But there are some anti-segment OCTs which can actually measure your sulcus depth. So that gives us a better idea about the overall white-to-white that we are supposed to implant. But most often, even I go by the digital caliper. That's what you used, isn't it? Yes. Digital caliper is probably, I think most of us use. OpScan used to be pretty good, but nobody uses OpScan now. All other parameters, because they look at the, it's more of an imaging system. They look at the color of the limbus, so it can actually be can mislead us.
We did a study on comparing the white-to-white diameter about through manual and the different 3-4 instrument, Pentacam, IOL master, all of that. But none of them actually come. There's a lot of variation between the manual measurement and the other instruments.
Topolaser Vario is okay. I mean, it is a little bit closest of all the other parameters which you have checked. Anyway, it's a good case.
Thank you. Thank you.
So the most reliable is topolaser?
No. Digital caliper is the best. Yeah, but this, see, once in a while, very rare case when the sulcus is very deep, you can come across a situation like this. So it's if you see a very low volts, that is the reason for it. But the other important thing is, if you have a very deep AC, like it's beyond 3 millimeters, it's better to oversize it even beyond that. Yeah. So next we'll have Dr. Tejas. He's going to speak on phakic IOLs, interesting complications.
Well, complications are always interesting. So I was also going to first of all talk on a rotating toric ICL, but I changed my topic. I'm going to show a cataract extraction following ICL and a removal of a phakic IOL. Ready? What do I do here? Okay. No. Yes. Okay. It's not happening. VL6, right? Okay, so this is about now 10 or 12-year-old video. These were the days when we actually did not have a centra flow. And so this is a normal IOL and this is explantation of an IOL. This patient was a second eye, and the patient really developed a very bad inflammation post-surgery and also rise in IOP, and the patient did not report to us for 2 days, thinking that the vomiting and all is because of something else. And as you can see, it ended up with a dilated fixed pupil, and we had to remove this phakic IOL. It is always a challenge to remove a phakic IOL when the patient is also phakic. And especially when you have to retain your crystalline lens. So here we are trying to create a space because there is a lot of inflammation. This is not something like a phakic IOL which you are going to exchange because of a size problem. As you can see, there is a lot of adhesions. Can you switch off those lights? I'm not sure whether, can you appreciate it good? Okay, fine. So because of this inflammation, this was going to be a difficult surgery. Just taking out the phakic IOL from the sulcus was also so difficult. And like I said, it was a challenge because we did not want to harm the crystalline lens. No, PI was done. PI was done, but probably because of the retained viscoelastic or first, I don't know the reason, but she developed this. And she reported after 2.5 days of the pressure. Not necessarily, because the other eye was already operated by AIOCMTC. We operated the other eye, she was fine, and she did not even turn up thinking that this vomiting and all is not related to the phakic IOL. And like I said, this is about 10, 11 years back. But I thought, let me share with you because I was also learning how to explant an phakic IOL at that time. I think I have only 4 minutes, so I'll try and... So this is the most important part, trying to grab the phakic IOL. We have to understand that we might have also made a tunneled incision. So the tunnel also acts as a wall, and it does not allow you to take the phakic IOL very easily. And you keep on, it's very difficult in a phakic patient to try and grab the thin haptic without damaging the crystalline lens. So I tried and tried, and ultimately I succeeded. Once you get a good grip, it's okay. And as you see, the pupil did not constrict at all. So this was one video, and then I have one with cataract. Yes, the pupil, yes, the pupil did not. There's a name to that syndrome which I keep forgetting. Yes. No, yeah. In fact, I'll just, the patient came to us in 2.5 days, and we were also not very sure what to do. We tried to constrict and do, like I said, this is about 11 years old video. I was also not that smart at that time. So we waited for another week before we actually thought of implanting, because the patient was -11, other eye was already phakic IOL done, pachymetry was 460, so we were also trying to debate कि क्या करेंगे, whether this will go away. Nothing, contact lens. Yeah. So this was very obvious, right? The patient developed a cataract. So you see now this technique is very easy. The railroad technique or whatever you call, you keep on grabbing. Hand rowing. Yes. That's why I chose 2. The one in which I did not know, the one in which I knew. And then once you remove the phakic IOL, it's pretty simple. It's a routine cataract later on. The only thing you need to be very careful is not to constrict the pupil. That's it. I think I'll end my presentation here. Thank you.
See this, removing the phakic IOL, you know what happens when you try to pull it out, it springs back.
Yeah.
And the other difficulty is because the haptics are very thin and it can tear and come with your forceps.
You bite it,
So you need to have the proper forceps, some serrated and wide forceps to hold the lens first properly. And once you pull it out, then you can do a hand over hand technique. And once half of the lens is out, it comes out very
In
easily.
fact, initially we were always, see, at that time the only player was ICL and they gave you those forceps, the reverse opening forceps. But I think that was a bad idea. Only our simple McPherson is the best, which should be good. Sorry? Yeah, that is the best way of doing it. Like we all learn all these things after our reach experience and listening to such talks.
I had done a phakic IOL, that is the antechamber IOL, and patient developed postoperative glaucoma, had Uret-Zavalia syndrome. But she was 6/6. The only problem she had was blur in the sense like when she went out in sunlight, a lot of glare. And she didn't want to explant it. After 15 years, she developed cataract, and recently, about 4 or 5 years back, I explanted and did an iris encerclage. I did a cataract and did an iris encerclage. So it can happen. Uret-Zavalia syndrome is something which can happen with high intraocular pressure. What happens is it's atrophy of the iris. So, yeah.
So one of the lessons which we learnt after this particular patient was, the patient was 120 kgs, she was a short neck, all that stuff, and probably our viscoelastic cleaning was not good. So now what we have started doing is, whenever we are in doubt, we first of all give a mannitol and then let the patient go. Then this has never happened. So that was one tip which I got. Yeah, now PI is, yeah, could be.
I think you must have done a lot of phakic IOLs. You can tell us what is the rate of explantation then and now, and if at all you're explanting, what are the indications? Your name is stages, so you can put some light on that.
Okay, pre-centraflow and post-centraflow, is that what you want to actually?
Yeah, also the time is not necessarily centraflow, it's also the maybe 10 years ago and now. How many are you explanting now and for what?
I would say in the last 5 years we have explanted none, and whatever we explanted was
very
before
gratifying.
That. Yes. But we are very strict in our regimen and choosing the patients. Any outliers, and we try to dissuade them from a phakic. Somehow we have become more mature, but none in the last 5 years, I would say. And like the patient of cataract, he developed this cataract after 9 years. So and this also was not a centraflow, if you saw. So the cataracts, the most important reason for explantation was a cataract, and one of that Uret-Zavalia syndrome. Otherwise, we have been very happy with our sizing also, and twice we did not actually explant, but we reoriented the phakic owl to make it more suitable inside the eye.
How many developed cataract? Forget about glaucoma.
In this 12 years, I would say 11 of them have developed cataract, and we have removed those cataracts.
And to the phakic IOL, not as a natural development.
No. I believe that was because these were all in their 40s now, less than 40.
See, these are all high myopes, and they have a tendency to develop early cataracts. So per se, because of phakic IOL, if it happens within 5 years, then you can say it's because of phakic IOL.
Also the location, it's more
Exactly.
anti-cortical.
So, if it's posterior, then it's definitely not because of that. Even we have a very, very low incidence of cataract post-phakic IOL, and explantation rates are very, very low.
I think thanks to the imaging techniques and our insight has also probably become broader. Now we know exactly which are the outliers and the selection criteria, and maybe the initial enthusiasm died down in the wake of the wisdom of all the complications coming up.
And especially now the only bugbear is going to be a plateau iris, where the iris configuration is not actually what it is seen on a slit lamp. In such a patient, whatever your sizing may be, these patients tend to develop, because I saw a friend's patient, both eyes implanted and UBM was done, and then we found out it was the plateau iris, very peculiar configuration of the iris insertion which led to this. Otherwise the sizing and everything was good. So there are always some exceptions.
They have a very bulky ciliary body, which is actually a plus
exactly,
organ.
yes.
In fact, I handled glaucoma in my hospital, and we used to, in the past, like 10 years ago, like occasional patients coming up with all the problems. But I think last 5 years, even I have not seen a patient from a refractive department coming glaucoma problem to me, actually.
So you were trying to double check with me when you asked me that question. Thank you.
Yeah, sir, I think one important point that we got from you in the first case was you said you did not do anything heroic after the patient had a complication. You just counseled the patient and gave an contact lens, which I think is a very, very important takeaway for all of us who are doing here, that not to get your ego in between and do what is best for the patient.
And the contact lens fitting in this patient is, the patient was already on a contact lens before the surgery. So it was very easy. In fact, that's the main counseling between a phakic IOL and a LASIK. That this is absolutely a phakic IOL is a reversible procedure. It's very difficult to fit a contact lens on a patient of LASIK.
Thank you so much, Dr. Tejas, for the wonderful videos. I would like to call the next speaker, Dr. Prasanna Venkatesh. He'll be speaking about gonioscopy, always a silent guardian, a watchful protector, and a dark night in clinical practice.
Thank you for this opportunity, ma'am. So mine is a slightly a controversial case, and a patient who had an ICL elsewhere and landed up with glaucoma. So a 24-year-old who had an ICL surgery done elsewhere, he had defective vision in his left eye on post-operative day 10, and obviously he is not happy at the age of 24. So before the patient presented to us, he had defective vision, corneal edema, IOP of 24 millimeters of mercury, despite maximum tolerable medical therapy. He was diagnosed as a secondary angle closure glaucoma, and also a secondary procedure of peripheral iridectomy was also done outside, despite a patent hole in the center, and he was diagnosed because of a pupillary block phenomenon. So the PA was done, but still the signs and symptoms were persistent. The IOP was not controllable, and the provisional diagnosis was still secondary angle closure glaucoma, despite a maximum tolerable anti-glaucoma medication therapy. And he was also advised an ICL explantation, and that is when he presented to us for a second opinion. So this was on our plate to actually manage. So when examination was done, the right eye also the ICL was done, but that was perfectly fine. The left eye, obviously a surgical PA was done because of the second procedure at 9 o'clock. Vision was 6/9, and the IOP was 11 and 24 millimeters in right eye and left eye respectively. And this is a clinical examination. The ICL was well placed with the patent center opening. The anterior chamber was deep. The ASOCT was fine, and the 12 clock hours ASOCT vaulting was actually checked. The chamber depth was very much fine. The biometry was done. The vaulting was again checked. It was all perfectly fine. But then we also felt, let us do a gonioscopy and see. And the gonioscopy between the right eye and left eye, it seemed to be slightly heavily pigmented in the left eye compared to the right eye. And the re-diagnosis from a secondary angle closure glaucoma was made to a secondary open angle glaucoma, moving to a normal depth, a heavily pigmented trabecular meshwork, and the normal vaulting of the ICL and otherwise. So we felt there was possible manipulation of the ICL, which could have led to a lot of pigment dispersion in that particular case per se. This was a possible hypothetical mechanism that we felt could have actually caused the trabecular meshwork to get obstructed for him in the first place. That could have caused a lot of liberation. The two procedures may be the reason we could not really hypothesize clearly, but that was a possible thing we felt. And the patient was not willing for an ICL explantation at all. He was a type A personality, and IOP was also not able to be brought under control. So there was two options. Either we went ahead with trabeculectomy with Ologen, keeping in the young age of that particular patient. For this scenario, trabeculectomy seemed a better option than ICL explantation, as the patient had a high bilateral high myopia. So unilateral explantation was not really the right way forward for him. And also, if we explant the ICL, and after that also, if the trabecular meshwork does not recover, then again we'll have to go ahead and do a surgical intervention. So why not go the other way around and see whether we can salvage the ICL at least for this particular patient. So initial presentation, he was on 3 medications. He was on oral acetazolamide, also the carbonic anhydrase inhibitor. Post trabeculectomy, he's doing well. Current follow-up, you can see 1 week, 2 weeks, 30 days, 120 days, and also the 5-year follow-up has been completed for him. His IOP is still in the low teens, and this is the final follow-up picture of the anterior segment, as well as the surgical PA initially done elsewhere. And this is the patent ostium for him. The bulb is healthy and it is functioning, and the patient is happy. His target IOP is well within reach, and there is no structural damage. Functionally, the patient seems to be doing well. And literature also says there is some advanced pigment dispersion secondary to phakic ICL. It has been rarely reported. So the one particular history takeaway is this patient was never done a gonioscopy before he presented to us. So it seems to be something very simple. So there were many flashy equipments in our armamentarium today as ophthalmologists, but a simple gonioscopy actually gave us a clue that the trabecular meshwork is where we need to focus on. And sometimes all we may need is a gonioscopy, which may not be our flashy hero, but at least in this patient it served as a dark night and a watchful protector. Thank you.
And thanks, Prasanna. I just have one question. If you had done gonioscopy before surgery, you would have not done phakic IOL for this patient?
Maybe, ma'am, because we didn't do the ICL. I'm not an ICL surgeon, but.
But I'm just asking you, how many of you will not do it just because there are more pigments, slightly more pigments in the trabecular meshwork? They will go ahead and do it because I think the lesson here is maybe this was a borderline case of pigmentary glaucoma, which has been missed. And sometimes, surprisingly, you see them most of them come in a very young age group, 20 years and all that. So the subtle signs is what we have to look for. And most often the refractive surgery is more interested in getting the case than trying options to removing it from his list. So that is a problem. So, but anyway, it's a very interesting presentation.
Thank you, ma'am.
I just have a comment. I think I told Dr. Tejas that I don't get glaucomas due to ICL, but we have been in refractive surgery business for 20 years. I do get a lot of primary open angle glaucomas in myos, which is a normal association.
Yeah, correct.
So a lot of patients actually who have undergone LASIK or whatever, they do develop glaucoma as a natural consequence, not because of your surgery. So I think that should be kept in mind. And this gonioscopy being the savior, I may not buy it fully because even as Sujata said, doing a gonioscopy before or after doesn't. The problem, what I can probably connect from the dots is, there was probably a pigment dispersion which you should be able to even demonstrate with the imaging. And there's a heavily pigmentation unilaterally. So that probably could be the reason. And most of these pigmentary glaucomas have a natural course and they tend to go down and the pressures tend to normalize. And it is probably a good option to do a trabeculectomy because obviously you can't wait for the natural course. It will take a long time for it to stabilize. And keeping that, there probably would have been a combined mechanism. He probably was a POAG in evolution and the pigment dispersion probably tipped the balance.
Other thing we have to keep in mind is steroid response. So
That is additionally, yes.
That is
But
an
it would be
additional.
usually bilateral.
Sometimes, one eye shows more because there's an additional risk factor in that eye. So I have a patient whom I operated 5 years back, and angle is open, everything is fine. She's still on Combigan.
Okay.
So, I mean, these patients probably they were missed earlier. They were missed prior to the
So
surgery.
basically you are preponing their POAG, which would have happened probably over another 20 years later. So steroid response, pigment dispersion, and probably it was an angle which was destined to become a primary open angle.
Probably it was not a very clean surgery. The surgeon might have led to more pigment dispersion and then again that would tilt.
There was also 2 procedures, ma'am. Like they again went in and did the surgical PA also. So we didn't have a clear history of what really happened in the 2 procedures. So maybe not an ideal patient for ACL. Maybe don't know, ma'am.
I think surgical PA should avoid. If you need to do the laser PA, try the surgery.
But already there's a central flow, no? These lenses come with this. Yeah, now it's come. Yeah.
It's narrower
Yeah.
and some.
No, earlier, I mean, during that era, we were actually trying to do a surgical PA just to make sure that it doesn't close. And we were doing multiple laser PAs.
I
We used to
have
have
one
2-3
question
PAs.
for the glaucoma specialist here. If you come across a patient like this, would you do an SLT?
Oh, okay, that was there. See, ALT would work very well theoretically in case of a pigmented trabecular meshwork.
Yeah.
SLT would also probably, but I think ALT and SLT are for so-called primary open angle glaucomas, not in a case like this where probably the pressures are very high, patient is young, and you can give a trial, but that won't be the salvation. You will not be able to come out of this unscathed even with SLT, ALT. You would still require medications. But it was probably a good idea to do a safe trabeculectomy because always if you are planning to do surgery, do it early to save the optic nerve rather than to just wait and watch.
It was an
And I think the pressures will probably decide. If the pressures are manageable with medication, you can hold on. The pressures are too high on so many medications, maybe you can take a call.
We did think about that, ma'am, because of Sertel, the oral carbonic anhydrase inhibitors were also going for him, and we felt there was
That
no...
was a good idea to do a trabeculectomy anyway. All is well, that ends well.
Yes, sir. So far, so good for the patient. Thank you.
We'll go on to the next speaker.
Thank you, Dr. Prasanna, for an interesting case. I would call Dr. Ipshita Konar for smile in corneal opacity. And after that, it is Dr. Siddiqar Rahman. Please keep it ready. Yeah? Thank you. First, after the last one, I'll go back to the first.
Good afternoon, everybody. Thank you once again. I'll be presenting a case of smile and corneal opacity. So obstacles or opacities can always come in our way, but then what's stopping us, right? We can always smile through it. So to introduce smile uses a precise femtosecond laser to correct -1 to -10 diopters of myopia and up to -3 diopters of astigmatism. The surgery is performed in 3 simple steps of a femtosecond laser being used to create a thin contact lens-shaped layer of tissue beneath the surface. The lenticule in the eye is removed through a small opening, and by removing the lenticule, the shape of the cornea is adjusted and the refractive error is corrected. So here we present a case where the left eye of the patient who desired smile for refractive correction had an opacity and vascularization at 90 degree, where we would usually make the opening to remove the lenticule. So this patient had consulted somewhere else for a refractive procedure and was denied a refractive procedure for the same reason and wanted a second opinion. Now, it is true that the corneal opacity may interfere with beams of femtosecond laser and hence makes the result unpredictable. On examination, the vision was 6.6 and 6, both eye, everything was within normal limit except for the deep vessels and the corneal scar superiorly in the left eye. So these were her refractive errors. Now we realized that the entry wound for the lenticule extraction could be impeded by this opacity. So we made a small modification of changing the entry wound to 150 degrees. Why we chose 150 degrees? Because it would be a comfortable position for the surgeon to maneuver the separation of the lenticule and its removal. For the right eye of the patient, smile was carried out as a routine procedure. For the left eye of the patient, the incision to remove the lenticule that is usually carried out at 90 degrees was instead shifted to 150. So here are the steps of the surgery. After the initial docking, the posterior lenticule cut which is outside in was made. And then the anterior lenticule cut inside out. And then here we are making the incision at 150. The opening of the lips at 150 where the incision was made. And then the posterior plane is being dissected with easy maneuvering by the surgeon. And then the anterior plane is being dissected. And then the lenticule is being removed. So finally, to finish up, we're just checking for the intact lenticule. And on post-op day 1, the vision was 6.6 and 6 and the opacity untouched. In literature review, there's an article by Tommy C.Y. Chan which says that the effective location of opening incision on astigmatic correction after smile shows us how astigmatic correction is not affected by changing position of incision, and there's no difference in visual or refractive outcomes. In our literature search, we did not come across other studies about smile being carried out with the corneal opacities located where the incision needs to be made. So to conclude, the presence of corneal opacity does not always mean that the patient cannot undergo smile. Even though results of laser beam through the opacity does make the procedure unpredictable, if minor modifications are made as per the need of the particular eye, while maintaining a comfortable position for maneuvering by the surgeon, there is no change in visual or refractive outcome, and smile can be carried out in an eye with corneal opacity. These are my references. Thank you.
Smile.
I think conditions apply. I think that should be in bold letters. It's a very bold statement, actually.
With
No,
minor
but one thing,
modifications.
not made necessarily minor, but other than the change of incision, what else was different in this case?
Nothing else, sir. Everything, just that the positioning has to be
The
changed.
opacity
I mean,
was
what
not
did you
in the
really go
center. That's what, the opacity was not in the center.
No, where we
It was in
usually...
the periphery only.
No,
So
but the opacity was exactly at the place where we usually make the incision to remove the lenticle, and that's why the patient was being denied a smile treatment elsewhere or any refractive procedure, because it was exactly at the incision mark where we would
So
usually
did
make
you
it
measure the
elsewhere.
depth of the, this one, the opacity, how much it was coming to the anterior stoma, and was it in the plane of your anterior part of the
Stromal
anterior cut? Was it
It-
in that dissection, was there a problem? Was there any adhesions? You had any trouble in that
We
area?
did not touch the area only, so no, while removing the lenticule, no, there was no issue. But when
No,
we
what
did
was the
not
depth?
measure,
Was it coming up, was it just superficial opacity, or was it coming out to the anterior stoma?
it was coming to the anterior stoma.
So
We
was it
didn't
in the
measure,
part of
we
the
didn't measure.
lenticule that we dissected out?
No, it's exactly at the margin, sir.
No, what I'm trying to say is, will opacity, or you want to like claim that if at all it's coming in the way of the lenticule area, will it probably, predispose to incomplete lenticule or a torn lenticule? That's the point. Because that is where you say that you can do with corneal opacity, conditions
No,
apply.
there
we
are a
talking.
lot of studies which talk about corneal opacity and smile where the opacity is in the area of the lenticule, like in the center where the lenticule will cover the area. So in those cases, it's quite debatable. There are a lot of results where, the measurements and the depth, everything is changed because if it has been carried out with the opacity in the center. But in this case, the opacity is not where the lenticule will be. It's exactly at the margin. But only the incision from be removed, we would have to go through the opacity. If we would go by the traditional way of doing an incision in 90, we would just go through the incision itself. But since that incision is also being made by the laser, there's always a doubt that if that incision will be right and if there will be adequate depth and if there will be adherence or if we can actually remove it. So we just shifted the incision. Rest of it, when we removed the lenticule, this opacity was exactly at the edge of the lenticule that was removed. So it did not, there was no, we also anticipated that while removing the lenticule, there will be any adhesion while that part, but there was nothing. It worked very smoothly. I guess we were quite lucky also that it worked smoothly. Thank you.
Thank you, Dr. Ipshita. Dr. Siddiqar Rahman would be speaking about phakic IOL implantation in mild to moderate keratoconus patients, a case series.
My respected chairman, co-chairman, moderator and co-moderator and the audience, good afternoon. I am Siddiqur Rahman from Bangladesh. I am sharing my experience about the visual rehabilitation of the keratoconus patients of my experience. I have no financial issues to disclosure. We know the keratoconus patients are the treatment of the keratoconus is a collagen cross-linking for the stability of the disease, the whole process of the disease. But for visual rehabilitation, we use contact lens is the preferable. The spectacle sometimes may be tolerable. And Intex is very good option, but the lack of skill and the cost, sometimes we could not afford for the patients. And for phakic IOL, I used IPCL and ICL both my patients because in Bangladesh ICL was introduced in 2019 and we got the IPCL in 2017. I started from that. And the IPCL or ICL, both surgeries can be done in normal the cataract surgery setup, so it is surgeon's comfort, and no maintenance is needful for the patient if it goes well. And both lenses have the wide range of correction opportunities and the different sizes of the lens. So we routinely what we do for a ICL or IPCL surgery, for the keratoconus patient also we do that. We choose the patient according to, especially we choose patient the keratoconus suspect to moderate keratoconus. That means when the spectacle correction is at least 618, then we went for the surgeries, because the patient expectation we have to counsel first for this reason. And other procedures are simply what we do for the other surgeries. And the investigations also we do the corneal tomography and the internal ACD. Here is an interesting issue. All the keratoconus patients have the very high internal ACD. But we should check the gonioscope, and we will measure the angle, because some false euphoric condition may happen. There is very deep anterior chamber, and we will got, if it has no problem, you have a very good anterior chamber depth, but angle may be narrower. So, but we checked all patients, and if we go for this area, in reading we see the anterior chamber depth is 4.25 or something more, but we got the anterior chamber angle is 35 degree, and it is enough. And less than 30 degree, we should not go for this type of surgery. And this is the way we discussed before. The measurement of the white to white is sometimes it may make us some confusion, which should be done or not. But usually we do not face any problem. We only did 11 patients as 17 eye of the keratoconus or keratoconus suspect patients, and visual outcome is very satisfactory with their spectacle, what they have with their spectacle, not contact lens. But all the cases have near to contact lens vision. Their outcome is like that. But no statistical data I am showing here, because it could be boring for, and we are running this study, just started a few days back. And this is one of my patients, just after surgery. Just after surgery, he could see all the visions. And they know vision chart is in OT, but a clock, you can see fine. That was the postoperative condition of this patient. The anterior chamber depth differs in both eyes. The left eye is worse than the right. Worse, that means the keratoconus is higher. And this anterior chamber depth is higher here also. And so the vault size is higher here also. And all the thing is going well. I thought I started this in Bangladesh first, but later on when I searched for the journals, there are many journals there, and in India, Ritu Arora and the Rohit Shetty, and many surgeons are doing this. So I am not the first one to do the ICL or IPCL in the keratoconus, but in Bangladesh I started this, and I hope it will be a good option. And take-home message is we should investigate the patients and take care of the patients very cautiously, and angle measurement we should take care of that, and proper counseling and regular follow-up is very important. Nothing problem happened till now, but we have to wait to see for the future. And thank you all for.
Thank you, doctor. I have one question. What is the astigmatism, the spectacle corrected astigmatism you take as, like if it is
I gone through up to six diopter cylinder, and ICL do not make the 6, they do up to 4 diopter cylinder.
Okay.
But IPCL they made it, but not actually fully corrected. We can go.
Okay. See, the problem with these keratoconus is the cylinders are not regular cylinders, irregular cylinders.
Exactly.
So once you correct one axis, they will develop cylinder on the other axis. So you have to counsel them really. But I do have a lot of patients whom I've implanted, but I make sure they are high myopes as well, because if there is a correction of high myopia along with the astigmatism, then they have better benefits. There's no harm in doing in low myopes also, but I feel when it's combined, the keratoconus combined with high myopia, the benefits to the patient
patient
is more.
satisfaction is higher at this
Patient
moment.
also is, because the spherical component is corrected, they are much more comfortable.
Exactly.
But now with all these mini scleral and scleral lenses which have come, all these patients, I really push them towards the lenses, because the quality of vision that they get with these lenses is amazing. I've had
Yes.
patients who have 3/60 correcting to 6/9. So that also has to be kept in mind.
Thank you, ma'am. Actually, we offer first the mini-scale lenses, but some patients, their lifestyle or their condition is not compatible, then we offer this with a compromise expectation.
Dr. Sujata, what about multiple procedures like topoling PRK followed by an ICL?
I have done that also. I have done that topoling PRK. That's possible in high myopes, where you're not correcting the spherical component, only trying to do an
Normalize the surface.
normalizing the cornea. I've done it, but really I am not really for a keratoconus which is beyond -3. I'm not a proponent of doing unless associated with high myopia. I would push them towards more towards contact lenses. But if the patient is insisting, today is the patient's world. If the patient wants it, I still do it. But definitely, they are not. You don't get the correction that you want. Patients are sometimes happy, very happy. They have -4 cylinder residual and still they are happy. So that is a different part of it. But uncorrected vision you cannot get. What's your?
No, our center is doing that. They have got some initial success after topoling. They have planned a phakic IOL, and some of the patients are doing well.
Yeah. The other problem with the keratoconus is the high rate of rotation, because they have very deep anterior chamber. So that also has to be explained to them. And there's a paper which says you put only don't put a toric lens. You just put only a spherical
toric lens. I put toric lens. All the patients.
Yeah, no, there's a paper which says you just put the
And
put a
correct the
spherical
cylinder
lens.
by glasses.
Yeah, correct the cylinder with glasses.
Oh, then the rotation will not happen.
Rotation will not.
It's the right suggestion. Thank you, ma'am. Thank you.
Thank you, Dr. Siddhikar. So the last presentation for the day is by Dr. Doyle Biswas. Is she here now? She's not here. All right, so that will be it for the session.
I think if you have time, Dr. Sujata, you can probably summarize the things and probably we can.
I think today's talk, I think most of it is spoken about phakic intraocular lens. And the most important thing that we found was that white-to-white measurement is key in every case. And also the anterior chamber depth. The cutoff is 2.8. Though, in Caucasian eyes, they have better AC depth. Beyond less than 2.8 is not advisable to go for phakic intraocular lens. And as you start doing it, you will realize how very important it is to do the white-to-white and then plan your case accordingly. If you have 11, they'll give you a 12.6. If you have 11.4 also, they'll give you a 12.6. Because it's not just 1 millimeter above the correction. So it's for you to decide, not the company to decide what is going to be the overall diameter of these lenses. That is one thing. Second thing is, you should keep in mind that very low volts, nowadays there were some presentations which showed even with very low volting, if there is a central flow, there is no cataract. So there is no need to jump in and go and remove these lenses. You can always wait. And other than that, intraocular pressure has to be kept in mind. And normally I admit the patients for 2 hours and just make sure that the pressure is not high, and never close the wound very tight in these patients. I just make it moderate. Even on the table, the pressure will not be more than 20. So that's very important. If you hydrate the wound too much and close it very tight, and then post-operatively, it takes a longer time for them to settle down. And of course, other complications associated with glaucoma and all that. Posterior segment is very important. And make sure that you get a retina surgeon to examine all these high myopes, because some of these lesions we may not pick up because we're not routinely doing indirect. And you have to actually depress and do the retinal this thing. And retinal barrage is important. And in my practice, what we do is we routinely do a specular, and also we do an OCT RNFL. Maybe it helps, it doesn't help, but just to ease my conscience, I do it.
What's your oldest phakic IOL patient?
2006. I did my
So
first phakic
it's
IOL.
around 16 years.
16 years, yeah.
So what will happen in another 10 years? Will they develop cataract? They will continue to do well? What's your expectation?
I have had only 3 patients who has developed cataract, and I have explanted the lens and put in an intraocular lens. All these years I've never had cataract. So many, that's why the incidence when you read is 4.1%. We don't get that many cataracts at all. I think probably the era before the vaulting, the B4 lenses came, the lenses were made just like intraocular lenses. Those areas, because the touch was more and there was no central hole, we had more cataracts. But nowadays, I think overall all the phakic IOL surgeons will say it's a very safe procedure. And I would like to say, even if patient is -3, patient wants phakic IOL, I would go and implant a phakic IOL, because the only downside is it's a surgical and you have to take all the precautions needed for surgery. So other than that, there's no contact. I've done.
Why -3? I mean, why that number?
Because it's a refractive procedure, and patient doesn't want to wear glasses or contact lens. So, so when they are not fit for LASIK or even a surface ablation, and patient has good anterior-chamber depth, we can do -3 refractive. I have done phakic IOLs.
No. How does the patient decide that he wants an ICL if it's -3?
Patient.
No, it's your call, right? It's your call.
If they are desperate, they'll say, do it somehow. And then they'll say, can I come back after my cornea thickens? Things like that, then we tell them there is an option, but it's a surgical option. You can take a look at the video how it is done, and then the decision is yours. So what is the difference between doing for a -11 and -3? The risk is the same, the age group is the same. So there's no need to deny them of this.
Ma'am, one question. If -3, why not to go for AC?
No, patients who are not eligible for LASIK.
Not eligible for laser correction. What about you, Dr. Tejas? Your threshold for phakic IOL?
Threshold for phakic IOL. Well, so I just wanted to come back to one of the points of 16 years. The vault is going to be very decisive. We have been told so many things. The second was the viscoelastic to be used. If the vault is only, they say half to 1.5. Now half is about 250
Yeah.
microns. Right? Now the lens thickness grows by about 0.01 micron every year. So it's going to grow, and these are the patients who are going to come back with some kind of a altercation. Our threshold for phakic IOL is now becoming very less, because we are using more of surface ablation, and we go up to 470. So our threshold of phakic IOLs has started going up and up. In between, when we were not very reluctant, we were very reluctant to do surface procedures, it was like 5-6 also. But now anything less than 460 is our first choice of phakic IOL.
No, I'm not. I'm not looking at normal corneas. Corneas which are have keratoconus component or early features of keratoconus, where we cannot do it.
If there is keratoconus component, then even a phakic IOL is also not a good idea, because it's going to be an irregular astigmatism.
No, patients who don't have astigmatism.
If I have to answer corneas less than 460, I'm not talking about the refraction. Because anything above 460, we can go ahead and do a PRP.
No, one more narrative, very interesting thing I want to ask you. Like you said, for a person who is ineligible for laser vision correction, you are thinking of even in low myopes a phakic IOL.
Yeah.
Why not in a normal cornea? Why not in a person who is probably eligible for laser vision correction? Why not why not a phakic IOL? Why you don't actually prefer it as a primary procedure?
Yeah, the only reason is because it's laser. Patient wants laser. They want something which is not a surgery. So when I tell them there is surgery, then then they come back, because why can't I do laser for my eyes? So the whole intraocular procedure. It's a surgery. All said and done, it's a surgery.
For a patient who probably doesn't have this mind block, like will there be a day in which probably you will prefer a phakic IOL over laser vision correction because of its potential reversibility, and maybe things get more safer in future?
No, sir, no. I have not gone that far. I still prefer.
I'm saying the future is a more refined laser vision correction or more refined phakic IOL.
A patient with -8 is definitely, or 6, has a lot of magnification. So I would go ahead with the phakic IOL, because the quality of vision with the phakic IOL is 100 times better
I was coming to that. Yeah, I was coming to that.
Exactly. So I took you there.
So the kind of aberration that we create and the final quality of vision, because we are not using Pellier-Robson chart in our clinics, so we are okay with Snell's acuity, but the patient has its own share of problems. Probably in future, as we go more refined, we'll start looking at more of aberration that we create with laser.
KP, I would say this, everything you'll have to step back a little bit because we have to look at the medico-legal aspects to it. Tomorrow, if something goes wrong, and then you go to the court, when everything was normal, why did you suggest phakic IOL? Whereas in the -3 case, which has a potential keratoconus, then I can say, I gave the choice to the patient to go back to contact lens, they wanted phakic IOL. I will have no word to say in a court when everything is normal and you did a phakic IOL. An intraocular surgery. Patient develops endophthalmitis. See, it's not unheard of.
The preference will be always laser procedure first and then.
Yes, absolutely, absolutely.
Sir,
Yeah, yeah.
at present, but if you have patients with, let's say, very visual requirement that is much higher than normal, I think we should prefer more of phakic IOLs rather than
yeah,
laser vision
absolutely.
correction, because as sir said, 100 times better vision.
Beyond -8,
Yeah.
it's better to go for
So
phakic.
we've had surgeons that we've implanted, could have done LASIK, but we've implanted phakic IOLs because you need better vision. Clarity of vision is better in phakic IOLs.
Absolutely.
The reason
Yeah.
beyond 8 now we are all preferring.
Yes, absolutely.
Probably that number will come down.
Thank you. Thanks a lot. Should we take group photo?